Thank you.
Here you go.
Thank you all for coming. It's really an honor to get to be here with you. And I'm going to tell you a little bit about my own research, but also my understanding of the broader field of health economics and what it has to say about health reforms. And I know that here in the Netherlands, you are thinking about what patient cost sharing should look like. You're thinking about what services should be covered. These are issues that are being wrestled with developed countries across the planet. And thinking through what the evidence tells us and what additional evidence we need, I think is a really productive way to gauge next steps. So I'm excited to be here, and I'm looking forward to answering questions, and I'll try to stick to time so that there's plenty of time for that excellent moderation. So when I think about the goals of reforming a healthcare system, there are, of course, many goals, but I think there are two big buckets. The first is controlling what we spend on healthcare. As you've heard from CPB analysis, healthcare spending is rising as a share of GDP in the Netherlands. It's much higher in the US. We probably spend about 20% of GDP on healthcare. And as a health economist, one of the first questions that people often ask me is, what share of GDP should we spend on healthcare? And my answer is, I think that's the wrong question. It doesn't really matter what share of GDP we spend on healthcare as long as we're getting high value for every dollar we spend. And by value, I mean each dollar spent should improve health as much as possible. And is that dollar worth spending? Well, we have to compare it to the other things. I'm sorry, I'm going to say dollar the whole time, even though I mean translate to euro. Should we spend that extra euro on education or housing or food? Or should we spend it on healthcare? It depends how much good it's going to do. So I think the right question is, are we getting enough value from our system? And I believe there's ample evidence in the US, in the UK, in the Netherlands, across the developed countries that we could be getting a lot more value from our system if we focused our resources on the care that improved health the most. Now, people do a lot of international comparisons. If we spend 20% of GDP on healthcare in the US and you spend more like 10% here, does that mean we're spending twice as much too much, or does that mean you could double your healthcare spending and that would be a good thing? I think those comparisons can be very misleading. First of all, the answer depends a lot on the population and the population's health needs. When I look at the US, we have parts that look a lot like the Netherlands, and we have parts that look a lot like less developed countries, all under the same system. And so what the people need from the healthcare system and how sick they are when they enter the healthcare system looks very different. In the US, we have much higher rates of obesity and non-communicable diseases, heart disease. We smoke less, so, good on us for that. But there are a lot of health challenges that the population faces that forecast higher healthcare spending needs. So it's a little bit apples to oranges comparisons to look across countries. But that said, I think even when you look within a system, we can find lots of examples of overuse of some kinds of care that are not producing enough value, and underuse at the same time of other types of care that would produce enormous health benefit if people had access to it. So all of that suggests that we could do much better in allocating our resources. So first goal I'm going to rewrite not as controlling spending, but rather as increasing value. Now, a second goal is access to that high-value healthcare. Does everybody have the chance to get all the healthcare that they need? And in the US, we have a very different problem of uninsured populations that you don't have here in the Netherlands. But I think that also masks a lot more nuance. Even in countries with universal access or universal care, there are widely different levels of access to care for patients with particular needs. And even in systems where people ostensibly are using the same health insurance system, we see higher income people opting out of systems that would otherwise have them waiting in queues to get care or going to other countries to get care that's not approved in their country. So even countries with universal systems don't look all that universal. And even in the US with higher uninsurance rates, the uninsured are still using lots of care that is subsidized through other mechanisms. So again, it's a continuum. It's not such a black or white issue. One of the main reasons to expand access to care is for people's health and well-being, of course. But there's also a hope. shared in a lot of countries, we might have talked about that a little this morning in Parliament, that if you expand access to high-value care, you might actually save money. That somehow when people have better primary care or better preventive care, they will go to the hospital less, they will go to the emergency room less, and that will actually save money. So expanding insurance could be a way to reduce healthcare spending and increase value. So maybe you can achieve both of these goals with one simple policy. Well, that could be true. It might not be true. You really need to look at evidence to know the answer to that. And there are lots of stories that sound nice, that we really want to believe, that don't hold up when you look at the evidence. And this is a really important case because healthcare is, of course, so deeply important to everyone. It's an emotional issue. It's not something people come to with their fully rational economics hats on. Of course, I never take mine off, but it's very hard to approach this with an economist's cost-benefit analysis. Let me give you an example from the US. I'm going to be talking about Medicaid, which is the US program for low-income people mostly. If you do a very simple comparison of the mortality rate of people who are on that Medicaid program, where they get free care, pretty much unlimited, to the mortality rate of the uninsured, who have, in essence, infinitely high deductibles and copayments. They don't have any insurance. If you just compare naively those two mortality rates, people on Medicaid, the low-income insurance program, have a higher mortality rate than the uninsured. You might be tempted to conclude that Medicaid was killing people and insurance is a terrible thing. It's bad for people's health and we should stop that. Of course, that's not a reasonable conclusion. I mentioned a moment ago that the way you get on Medicaid is by being low income. Being low income is hard on your health. In every country, higher income people fare better than lower income people. So being on Medicaid signals all sorts of other challenges for health that translate into higher mortality. It's not that the insurance program itself was bad for people's health. So you really do need hard evidence on this. And as you heard in the introduction, that evidence is hard to come by. We don't do randomized controlled trials of large public programs very often for good reason. There are, of course, logistical constraints, but ethical concerns. If you wanted to know the effect of education, you wouldn't say, okay, your kids can go to school. Your kids, I'm just going to lock in the basement for the next 18 years and see what happens. We would never do that. So it's very hard to get that kind of evidence. But it's crucially important. We had this rare opportunity to assess the costs and the benefits of expanding insurance. And one way to think about how to learn from this for the Netherlands context is, as I mentioned, the Medicaid program is free care with no deductibles. So think about removing a giant deductible and seeing what happens to people. The cost is people might use more care. Now, some people react by saying that's not a cost of eliminating barriers to care. That's the whole point. You want people to use more care. But of course, no one wants health care. With apologies to any of the doctors in the audience, people want health. They want to feel better. And health care is the resource that you use to get to that goal of feeling better. It's not the goal in and of itself. If we could all feel great and not have to go to the doctor, I think everybody would vote for that. So the cost is health care use. The benefit is, of course, health outcomes. I'm going to look at mental health and physical health, but it's also financial well-being. Part of the reason to have that insurance is to protect you against the financial risk of high healthcare costs, of not being able to pay for food or rent or things your kids need. So I'm going to try to look at those benefits as well. This Oregon experiment that you heard alluded to, Oregon is a state on the west coast of the US. In the US, there's a huge amount of variation from area to area, not just in population health needs, but also in what the insurance programs look like. Medicare is a central federal program for people over age 65, but Medicaid looks different from state to state. In Oregon, they wanted to expand their Medicaid program for low-income residents, but they didn't have enough money to enroll everyone who might be eligible. So not because they wanted to generate the perfect experiment because they love health economists. It was because they had a limited amount of money and they thought the only fair thing to do would be to allocate those slots by lottery. So they opened up a waiting list. 90,000 people signed up for the waiting list, and they drew names to enroll 10,000 people in the health insurance program. And anyone whose name wasn't drawn remained uninsured. So this was not a desirable policy from a public health perspective. It was all they could do with the money that they had on hand. So we used that, me and my co-principal investigator, Amy Finkelstein, and lots of people that we worked with in Oregon and across the US, we used this as a chance to assess the costs and benefits of expanding public health insurance and reducing cost sharing for people. The experiment started in 2008. We collected data for several years after that, and I'm going to show you some of those data, and then I'm going to talk about other studies too, but you gave me a microphone, so I get to talk about my study first. So I will tell you a little bit about that. The population is very similar to the population being considered for expansion under Obamacare or the ACA, which at first was going to be low-income people in every state, but then the Supreme Court said states got to decide, and for a long time, many states didn't choose to expand when it was optional. More have chosen to over time, but it's a question being debated in many states across the US right now. And cost sharing around the world, I think, is being debated by lots of countries, including this one. So we got all the data we could. And this is really important because if you don't collect primary data on a lot of these questions, it's hard to know what the insurance product is actually doing. For example, suppose I ask you, moderator, how's your blood pressure? And you're insured and you've been to the doctor. You might say, I told me I had high blood pressure. So you tell me as the interviewer that you do. But then I ask you if you have high blood pressure. You're uninsured. I'm sorry, you don't live here. And you have not been to the doctor. Nobody told you you had high blood pressure. You can't feel high blood pressure. And you say, nope, my blood pressure is fine. And so then I, the clueless studier, think that your blood pressure is caused by having insurance. Insurance raises blood pressure. And of course, not a reasonable conclusion. Insurance caused your knowledge of your high blood pressure. It didn't cause high blood pressure. So you have to measure these things directly. And we went to great pains to collect all of the data that we could. This required collaboration with policymakers in Oregon, even though we tried very hard as researchers to shoulder the burden of all of the analysis, and we bought all the computers and we hired people to embed with the state so that they could do the analysis inside the state walls that needed to be done. It couldn't have been done if policymakers had not actively wanted to hear this information. And that's more challenging than anyone working outside of government might suspect. I bet people in this room have a very sophisticated understanding of that, but it's hard to ask somebody running a program, could we see if your program's actually doing anything or not? Most people say, no, I'm fine, my program's good, move along. And so it was, I thought, remarkable that people in Oregon said, well, we want to know if our program's working or not. Go ahead and study it and tell us the answer no matter what. That's priceless for advancing our understanding of what policies work and what policies don't. It also, I think, highlights the importance of developing relationships between researchers and policymakers to take advantage of every opportunity to learn from policy. When you're thinking about a new policy, there's a chance to partner to learn as much from it as you can, or you can ignore that and just roll out the policy, and then I think you're leaving a lot of opportunity on the table. So this was really wonderful for us, thanks to our partners at the state government. Now, I am in between each of the results that I'm going to show you. I put up some quotes. I'm not going to read them out loud. You can read them when you get bored with what I'm saying. The goal of these is to illustrate that for almost any policy, you can find anecdotes that support diametrically opposed different points of view. For every result that I'm going to show you from the data that gives you the average effect across a big population, you can find a person who had exactly that experience that illustrates the point I'm trying to make, and you can find a person who had the opposite experience that looks like it disproves the point that I'm making. For each person, the travel through the healthcare system looks different. The needs look different. individual experiences vary widely. That doesn't take away from the average results that you find when you study tens of thousands of people. You know what the policy typically does, but you can find people whose experiences vary, and that's the danger of using anecdotes to make policy. You can always find an anecdote to support any policy. It's not necessarily representative of what you're going to see in the whole population when you roll it out. So first question, what happens to healthcare use? Stories about it going up, stories about it going down. It turns out healthcare use goes up. When you remove that cost sharing and you make healthcare free for everyone, people use a lot more care. They go to the doctor more, they get more preventive care, they use more prescription drugs. I think all of this was relatively expected by people who were anticipating the study. What was not expected was that emergency department use went up dramatically. And this was a shock to people who were in favor of expanding insurance, because they thought if you could expand access to primary care, people would go to the emergency room less. Turns out they go more. And we looked at all sorts of reasons that might be the case. Economists were not very surprised. The emergency room used to be expensive, even though they can't turn people away who need care. They can send them a bill afterwards. So just because you have access doesn't mean it's free afterwards. And people were very worried about the bills. So, economists said, congratulations, you've just discovered that demand slopes down. Doctors were also not surprised. They said, if I have a patient who's in need of critical care and I can't see that patient right away, if I tell them to go to the emergency room, insured people will go and uninsured people won't. So economists were not surprised, doctors were not surprised, policymakers and advocates for expanding insurance were very surprised, and I have to say somewhat dismayed to see that this was the case. We also looked at financial well-being. Does having that insurance, the absence of any cost sharing, really improve people's well-being financially? And the answer is resoundingly yes. The odds of having a bill sent to collection, of having to pay, to avoid going to the doctor because of past bills, of having to get your friends to chip in to help you pay your rent, all of that goes down dramatically when people have insurance. So insurance is really good for people's financial well-being. But then the real punchline, what happens to people's health? Here it is a much more nuanced story. If you ask people about their health, the share reporting that they are in excellent or very good health versus the share reporting that they are in poor or fair health goes way up. People's self-reported health is much better. Their depression rates fall dramatically. We saw a 9 percentage point or 30% reduction in depression among the people who had insurance versus the people who didn't. Mental health, there's a huge unmet mental health need among this population, and this program did a lot to improve their access to care and their well-being. And in fact, most of the improvement in mental health seems to be attributable to people's increased access to and utilization of medication. There's effective medication for this. They saw a doctor who diagnosed their depression, prescribed medication that they took, and they felt better. So this is a huge benefit. But we did not see any improvements in chronic physical health conditions like obesity, like diabetes, like high blood pressure, like high cholesterol. We measured all of these things. There were no detectable improvements. Again, people were very surprised. They really thought, how could Medicaid or insurance not have improved blood pressure? Well, we found that people who we measured their blood pressure directly to avoid this problem that I highlighted, and in fact, their blood pressure wasn't any better, but they also didn't report any greater likelihood of having been diagnosed with high blood pressure. When we said, well, has anyone ever told you you had high blood pressure? Insured and uninsured were equally likely to say, nope, nobody told me that. And in fact, when we looked at all the medications they were taking, the insured were no more likely to have a medication for high blood pressure. So people said, well, maybe you just didn't wait long enough. I mentioned at the beginning, this is about 2 years, 2.5 years after people got insurance. One of the arguments in response was maybe if you just waited a little longer. But if you think about 2 years where nobody has told you you had high blood pressure and nobody's given you a medication for your blood pressure, at least you haven't filled a prescription, it's hard to believe that in year 4, suddenly someone's going to catch on. I think it's evidence of the inability of the US healthcare system, and I think a lot of systems in developed countries, to deal with the rising rate of those chronic physical health conditions. We haven't figured out how to cure obesity or high blood pressure for people who are insured by any program, and Medicaid here is no exception. Now, the story is a little different for diabetes. We had too small a sample to be able to rule out clinically meaningful effects on diabetes or diabetic blood sugar control, but there's enough of a population with high blood pressure in our sample that we could say the size effects that would be of clinical benefit, they're just ruled out. They didn't happen here. So that, again, I think was very surprising to people. So you put all of that together, and it seems like there is something for everyone to hate. When you look at the results, if you are in favor of expanding Medicaid, the problem is it doesn't save money. Lots of people were arguing that it would, because if you had, primary care, you wouldn't go to the emergency room. We also didn't see, and we didn't see that. People went more, as I said. We also didn't see any increase in the likelihood of working or, productive activity or use of social services. We looked at all of those different realms, and those benefits didn't materialize either. So if you expand insurance, if you lower copays and deductibles, it just does not save money. But on the other hand, we also can eliminate the unduly pessimistic view of the program, which was it's a terrible program, it's killing people, look at the mortality rates, and you don't even get good access to care, it pays providers too little, it doesn't benefit the people who are enrolled. Well, we can eliminate that story too. People on Medicaid are much better off than the uninsured. They are more financially stable, they have lower rates of depression, they have more access to higher quality care, they report that their health is better, they're clearly better off. So that leaves policymakers with a real dilemma. These are all headlines that came out after some of our studies. They're all real newspaper headlines. My favorite one there is how to use the Oregon Medicaid study to your ideological advantage, which is what we heard a lot of. And on the one hand, as a researcher, that's kind of disheartening. Like, you pour years of people's time, thousands, millions of people's dollars into this study, and then policymakers just kind of pick the parts they like and ignore the parts they don't like. So on the one hand, that could be disheartening. But on the other hand, I really do think that we narrowed the debate a bit. People stopped saying things like Medicaid's going to save money, and they stopped saying things like Medicaid is going to kill people. And instead, they focused on the much more productive questions. What's the most efficient form of health insurance? If we're going to expand coverage, what's the right way to do it? Why is the system not delivering benefits that actually reduce high blood pressure or that successfully fight obesity? Those questions, I think there's a lot of really productive work to be done. It's not very productive to talk about the insurance program saving money or killing people. Those things just aren't true. But there are a lot of open questions for all of us to be working on. And so I will now spend a few minutes talking about what all of this suggests for potential health system reform, and then there will be plenty of time for questions. So we could expand coverage in lots of different ways that would have different implications for spending on healthcare. And I am using that as a shorthand, having belabored the point that you should really be focusing on value. You also need that high value care to be affordable for the public system. You need to be able to balance the needs for healthcare against the needs for education, housing, et cetera. So I want to talk a little bit about provider side reforms, what we could do to change the payments to hospitals and to individual physicians. And I want to talk a bit about patient side reforms or enrollee reforms, how we might change cost sharing to generate higher value care. That requires policymakers to wrestle with some really important questions. I just talked about the costs and the benefits of expanding that insurance product in the US. The benefits are better mental health, financial health, well-being for people who get greater access. The costs are the tax dollars that have to pay for it. The challenge for policymakers is amplified by the fact that those are often different people. That may be more or less true in the Netherlands. In the US, most people on this public insurance program are not paying taxes, and most taxpayers are not eligible for the public insurance program. So you're trading off benefits to one group against costs to another group. And that is why nobody has elected me to be a politician, because that is a policymaker's dilemma that is really difficult to wrestle with. So on the provider side, I would argue that systems will be more successful when they pay for value rather than paying for care. And what I mean by that is that turns out physicians are humans as well, and they respond to incentives just like other humans, much as they might sometimes argue otherwise. How many doctors are in the room? Okay, I hope you're not offended. Excellent, I am doing great. So the challenge is that if you pay physicians more for certain kinds of services, you will get more of those services. When you pay hospitals more for certain kinds of services, you'll get more of those services. So the challenge is to pay in a way that is consistent with caring for the whole patient, not siloed by different pieces. If you pay for, diabetes here and heart disease here, there are a lot of people with heart disease and diabetes, and they relate to each other, right? Sounds true. So paying for integration of care provides a better patient experience and also keeps you from double paying for care that might not be all that beneficial for the patient. There are a lot of experiments in the US with bundled payments, for example. Rather, if you need a knee replacement, rather than paying you as the surgeon and you as the anesthetist and you as the nurse and you as the guy who made the knee replacement and you as the guy who provided the sponges and you as the person who cleans the room, all separately, if you provide one payment, that helps people integrate their work a little better and make sure that you don't get way more sponges than you might need for the service. Now, different countries take different approaches to that, but that payment towards value only for patients who would really benefit from a knee replacement, not for all patients, for example, can help drive higher health improvement for every dollar that you spend. One of the keys to making that work, though, is having really good risk adjustment, and that's someplace where I think the Netherlands has a very good system, although one that you might still add to. Knowing how sick patients are is really crucial to paying for value, because you do not want insurers to have a disincentive to enroll sick people. You want them to get paid more if they enroll sick people, otherwise they will try not to. You don't want physicians to worry that if they care for extra sick patients, they're going to receive less in compensation because they're not able to achieve the same level of outcomes. So you want physicians to be paid more to care for sick patients who have higher needs and are more complex to care for. Being able to measure that ex ante is really important and requires really good administrative data, and that's a real advantage here in the Netherlands. But I want to spend a little more of my time on the patient side, both because I think there's some really interesting research there and because I know it's top of mind for policymakers here. Thinking about cost sharing requires being more sophisticated than the traditional economics model. The traditional economics model imagines someone who is perfectly farsighted, perfectly rational, making great decisions for the rest of their lives at every moment in time with full information. And of course, that's not how human processors work. It is challenging to make decisions every day about anything, let alone about something as serious for your long-term well-being and that of your family as your health. And so the traditional economics model, I think, has been improved upon by behavioral economics, which looks at the intersection of psychology and economics to say, how do real people make real decisions with limited information available to them, with limited processor speed that we all have, with limited foresight, and with all of the human shortcomings of impatience and inattention and short-sightedness. Behavioral economics, traditional economics models would tell us that the only thing you need to know to set the perfect cost-sharing arrangement is how much people change their consumption of healthcare in response to the price elasticity of demand for the economists in the room. If I know that a $5 copayment will make you not take a drug, you were going to take the drug, but $5, never mind, That tells me in the traditional model that you value the drug at less than $5. Otherwise, you would pay the $5 and get the medicine. So the more you change your consumption of medicine with a $5 copayment, the less valuable I know that medicine is in the traditional model. Well, it turns out that's too much of a simplification. If I introduce a $5 copayment for a medicine, you're going to cut back on medicines that are kind of questionable benefit to you, but you're also going to cut back on medicine that is incredibly valuable to you. There are some studies looking at patients who are just getting out of the hospital from having had a heart attack. And there was a randomized controlled trial where some had a $5 copayment for medicine in that circumstance where it should be incredibly salient. I just had a heart attack. It was awful. I was in the hospital. I don't want another heart attack. And the doctor says, here's a beta blocker. It costs you $5. Or here's a beta blocker. It's free. The $5 copayment changes people's consumption of that drug. It changes their adherence to best practices, not just for very low income people for whom $5 would be a barrier, kind of for everyone. And that is very hard to understand in the traditional model. There's no story where that makes any sense. $5 copayments will deter people from taking anti-organ rejection drugs when they've had a transplant of an organ. It makes no sense. But we're all human and we've all experienced this. So what I and some co-authors have argued is that rather than just looking at whether $5, rather than assuming that the $5 deterrent effect means you don't value the drugs, we take into account these behavioral economics factors and think about behavioral hazard as well as moral hazard, which is the economist's term for that change in behavior in response to prices. And it turns out that a much more effective copayment system would be to make copayments really low for drugs or other services that are of high health benefit. If it's really valuable in terms of improving health, make it free, especially for low-income people. You don't want any barrier to care, for care that is of really high value. There is, however, lots of care that is of questionable health benefit. Given all of the advances in medicine, from drugs to procedures to devices, there is a virtually unlimited amount of care that we could provide to individuals. And if there were no barriers to any of that care, you would spend 100% of GDP on healthcare. And I think everyone agrees that's too much. We need money for food and housing and all those other things. So having a system that includes copayments for care that is of more limited health benefit would stretch public dollars a lot further. Now, next rational question is, so who decides what's high value? Like, do you just mean cheap medicine, and is it the government deciding, or is it the doctor deciding, or the patient deciding? I don't think that we can expect patients to have full information about how valuable different treatments are to them. Only some patients are doctors, and most people, myself included, would just need expert advice from our physicians to know what's valuable and what's not valuable. Nor, I think, can we expect individual physicians to solve the policymaker's dilemma and decide what is of best value to society here. You have a patient in front of you who has needs. You have your best recommendations about care. We can't expect in the moment the physician to say, but would this medicine really be better allocated to a vaccine for a totally different patient? Which is why I think you need public policy to draw a line and say, here is the care that is of sufficient value that we want it to be free for everyone. Here is care that's of moderate value. We want it to be accessible, but not quite free. Here is care that's of very low value, and if you want to buy it, you're on your own. I think a system like that would be a much more effective set of copayments towards higher value care, meaning stretching your dollars to improve health as much as possible. Now, what does that mean for the policymaker's decision set? The US context, again, is very different from the context here. We don't have to talk about uninsured populations in the Netherlands. And we also don't have to talk about the very patchwork system we have in the US, where people have different insurance at different points in their lives and at different months as their income changes. All of that introduces a separate set of problems. But you do have the dilemma that we all face, that there are new and expensive things coming over the horizon. And how are we going to afford those for all of the patients who might benefit from them? So the questions I think policymakers need to answer is, what is the floor of coverage? what do we think everyone should be entitled to? And I would argue it can't be everything. Like that's just more than 100% of GDP. It can't be everything. You have to decide what is the minimum bundle that every human should be entitled to, and we're going to pay for that with public dollars. But then another question is, should higher income people be able to purchase additional coverage beyond that or additional services? And I mentioned before that in a lot of countries where that is ostensibly not allowed, people find ways around it. People will travel to other countries. People will have their own ways to navigate the system. And I do think higher income people everywhere end up with more health care and better health outcomes. So one possible avenue is to just acknowledge that and say, everyone's going to have this floor that we think is sufficiently generous. A floor doesn't have to be stingy. And above that, if higher income people want to purchase more, okay. And there's a real advantage to that in that I think it helps drive innovation that's then available eventually to everyone as prices come down. And for all new things that are introduced, they're introduced at a higher price and then competition brings the price down. So there's a real societal return to having those extra resources drive investment in new things. But there's a downside in that higher income people and lower income people will fundamentally fare differently. And is that two-tiered healthcare system something that you find acceptable or not? And there's no economics answer to that. That is a matter of priorities and social preferences and ethics. From my own point of view, I think that higher income people get more of a lot of things. And pretending that that is not the case doesn't actually help all that much. So I tend to focus on making sure that the floor is as high as we can have it be, while not inhibiting innovation that would actually make everybody better off in the long run. But that's me, and as I've said many times, not an elected official. So that is up to all of the people that you vote for or are to figure that out. I will leave you with one last thought, and then I think it's time for questions, which is all of this has to be undergirded by evidence. There is so much hope around a lot of the stories you hear in healthcare, whether it's that expanding insurance will save money, or prevention pays for itself, or if we all just lived healthier, we wouldn't have to spend anything on healthcare. Those things would be nice if they're true. I haven't seen evidence that they are. And so it behooves us to generate as much evidence as we can to inform rational policymaking, and then do our best to elect people who want to use that evidence to make a better system for all of us. So I will stop there and turn to questions.